great. Um, so I started off studying medicine at Cambridge, or the other place, as people at Oxford call it. I know that this talk is obviously about studying medicine at Oxford, and there's a lot of rivalry between the two. To be honest, they're very similar. So this is an image of the college I was at, which is Girton College. I had a really great time there. There are some people who might think, you know what, if people like, to be honest, I would say that if you feel that you want to apply, then you should definitely go for it. One of the biggest things that I have found in my career is that it's way better to go for things, even if you don't achieve it or you fail at it, rather than to live the regret of not having even tried. And certainly when you do apply, they really are just looking at your academic potential. It's not about which school you go to. So I definitely would recommend you applying. So having completed 6 years of medical school, I moved on to my foundation years. So foundation years, or FY1, FY2, these are the first 2 years that you do after you complete medical school. And the idea is that you take through a number of different specialties, and hopefully it should give you a bit of an idea about which specialty you want to actually go on to end up in and specialise in. So my foundation years were in London, and the specific deanery was North Central Thames. So in my first year, FY1, I was in Basildon in Essex, and there I did 4 months of heart and lung surgery, 4 months doing urology, so that's surgery of the urinary tract, before moving to London to University College Hospital for my second year, where I did 4 months of accident and emergency, 4 months of general practice, and then finally 4 months of obstetrics and gynecology. So for me, when I was at medical school, I really enjoyed all of the specialties that I did. That made it very hard for me to think, which specialty do I actually want to go on to pursue? Funnily enough, the one specialty that I really didn't enjoy was general practice. So that was the one specialty I thought I knew I didn't want to do. So when I got to around this point, so by the way, can you see my cursor? Can you just put a thumbs up if you can? Oh, great, okay, lovely, thanks. So when I got to my first rotation in foundation year 2, that's when I put in my application for specialist training going forwards. And at that point, I thought to myself, I think I want to do obstetrics and gynecology. So I applied for an obstetrics and gynecology post, and happily I got a run through training post in Oxford. Having gotten that post, I moved on to my general practice block. Now, this was the block that I thought I really wasn't going to enjoy, but it really took me by surprise. I enjoyed it so much, and loads of the GPs said, you know what, we actually think you'd be really well suited to general practice. But at this point, I'd already got my obstetrics and gynecology training program post, so I thought, well, it's too late at this stage anyway. So I completed my foundation years. So having done foundation years 1 and 2, I then moved on to doing my obstetrics and gynecology specialist training in Oxford. So you may well be aware, obstetrics and gynecology, the obstetrics part is all about pregnant women and childbirth. The gynecology is more about sort of medical problems to do with women. So very soon into this placement in Oxford, I just knew that it wasn't really what I wanted to do. And I kept thinking back to how much I'd really enjoyed general practice. So quite quickly, I then changed tack. I applied for general practice training in Oxford, and luckily I was able to get a training post in general practice. So I only did this for 1 year. It should have been 7 years had I completed it. And instead, I moved on to general practice training. So I'm sure you're all aware of general practice, you've probably all been to a general practice maybe many times. And there are lots of things that I really enjoy about general practice. One thing is the variety that it affords. So, in the same GP surgery, I might see, first of all, a baby and do a newborn baby check. And then I might next see an elderly patient who's confused. And then I might see someone that I think perhaps they're having a heart attack and maybe I need to refer them to hospital. Then I might see a patient with depression. So there's so much variety and it really does keep you on your toes. Another thing that I really enjoy with general practice is the ability to develop a rapport with patients. So unlike in hospital medicine, in general practice, you do often see the same patient multiple times. And particularly for more experienced GPs, often they've seen a patient maybe from their childhood through to their adulthood and also their children. So you really sort of get to know your patients very well. And I like that sort of personal side of medicine. But each specialty does have its own frustrations. And one thing that I noticed during my training that I found quite frustrating was that quite a few patients who would have a viral infection, much like the one I'm sadly suffering with at the moment, and they would come to me and they'd say, oh, I really would like some antibiotics. And as I'm sure you'll all be aware, antibiotics don't treat viral infections, they treat bacterial infections. So this was one thing that I always found a bit frustrating. So just on the subject of sort of antibiotics, a little bit of a quiz here. If you can just either shout out or you can type into the chat function, can anyone tell me who this is? Oh, do you know what? I'm serious, I can't actually read the chat, but Will, can you tell me what's written in the chat?
Hi, yes. Someone's written Fleming.
Yeah, absolutely. That's excellent. Congratulations. So the person who said it's Fleming, do they want to say what he's known for?
Yeah.
Or type it? Or you can speak it out?
Hi. Yeah, so he was for penicillin.
Absolutely. That's brilliant knowledge. So just for the benefit of everyone else, so so this is Sir Alexander Fleming, and as your colleagues mentioned, he was the person who kind of first discovered antibiotics and specifically penicillin. So the way it happened, it was back in 1928. So he was a scientist and he was growing some bacterial cultures in Petri dishes, much like the dishes you can see in this photo, so all those kind of round plastic plates that you probably use in your science classes as well. So he was growing some specific bacteria called staphylococci. And he put some in a Petri dish and he went off on holiday. And I think perhaps because he was rushing off on holiday, maybe he didn't secure the dishes quite so well as he normally would have done. So when he returned from holiday, he realized that there was a contaminant, a fungus had gotten into the dish. So he was about to throw it away, but he noticed something quite peculiar, which was that in the areas where the fungus had gotten in, there were no longer any of the staphylococci, the bacteria growing. So something in the fungus was killing the bacteria. So he did further investigation, further research, and he discovered essentially penicillin, which he initially called mold juice, but thankfully he did think better of that name. But it was some 15 years or so before penicillin was then introduced into clinical practice. Now, we know that antibiotics like penicillin have saved many millions of lives. Maybe some of you have taken antibiotics yourselves, but it has, or the overuse and the inappropriate use of antibiotics has given rise, unfortunately, to a new problem, which is that of antibiotic resistance. So this is probably something that you've heard about, maybe, I don't know if you've been taught about it at school, but you may well also have seen it in news headlines, as you can see in this slide here. essentially of antibiotic resistance. It's a form of evolution of bacteria in relation, or that's driven by selection pressures placed on them, namely giving antibiotics. So within bacteria, they have their own genetic material. And this genetic material can undergo random mutations. And sometimes when the genetic material randomly mutates, it will make the bug much more resistant to being killed by antibiotics. And the more that we give people antibiotics, the more that these bugs are likely to develop resistance to them. And there are some of these bacteria that contain so many of these resistance genes that they're what we now call superbugs. So they're resistant to loads of different antibiotics, and it's really hard to kill them. So if somebody were to become infected with a superbug, as unfortunately happened in this case here, it can have really disastrous consequences. So you'll all be aware of, or you probably have heard of Professor Chris Whitty, who is the current Chief Medical Officer. His predecessor was Dame Sally Davis, and she frequently spoke about antibiotic resistance. As you can see up here, she has said that antibiotic resistance could actually wipe out humanity before climate change does. And many people have spoken about antibiotic resistance as the silent pandemic, because there is really a pandemic of antibiotic resistance, but it's something that really isn't being talked about enough. So probably the main driver for antibiotic resistance is overuse of antibiotics, as mentioned. And one way that we can perhaps, or as a GP, because about 80% of antibiotics that are prescribed to humans in the UK are prescribed by GPs. So one way that we can try to kind of reduce antibiotic prescription for viral illnesses, which are not treated by antibiotics, is by giving patients a bit more of an accurate sense of how long they should expect their viral illness to last. Because sometimes you find that patients might be unwell with an illness for some time, and they think, oh, I've been unwell for quite a long time. I now need antibiotics to sort this out. But if we can give them a bit more of a realistic timescale as to how long they're likely to be unwell with a particular viral illness, then that can help to reassure people that actually what they're experiencing is within the realms of normal. So a little bit of a quiz on this slide. Again, feel free just to, if you can, shout out. So I'm really sorry, I can't actually see the chat. So please just shout out, and maybe Will, if someone puts something in the chat, you can just shout out on their behalf. But if somebody has an acute cough that's caused by a virus, how long in days might you expect that to last? Any guesses? I think someone's put something in chat.
So we've got some guesses here: 2 to 3 days, or 1 week, 14 days.
Okay. Yeah, so it might surprise you to hear that 21 days, it can last really for maybe a lot longer than you might expect. So, you know, if someone comes in, they've been coughing maybe for 2 weeks, they might think, right, I need antibiotics now. But if they understand that actually their cough can last for about 3 weeks, then that hopefully helps them to put it in perspective and realize that it is actually within normal limits. So what if somebody has a viral sore throat or earache? By the way, this is a bit shorter than the acute cough, but roughly how long would you guess for this?
Someone's guessed 10 days.
Yeah, about that. So, oh, sorry.
Sorry, yeah, someone else has guessed 1 week or 7 days.
Yeah, so we would say 7 to 8 days for that. But if somebody has the common cold, how long would you say for that?
2 weeks?
Exactly, 2 weeks. Yeah. And if somebody has winter vomiting or norovirus bug,
Someone's guessed 3 days or 2 weeks.
so 3 days actually. So this one, typically it's a much more kind of acute illness compared with some of the other ones. And finally, if somebody has a sinus, I've just put the answer. Well, if someone has a sinus infection, again, it can be, 2 to 3 weeks. So, for some of these, it's a lot longer than you might expect. So just giving patients this sort of information can be helpful. And I did try to do this during my GP training, and even now I still do. But sometimes patients will still say that, look, I had an illness like the one I have now. And the last time I had it, I went to see my GP and I got antibiotics and I felt better. So can anyone, again, please just feel free to shout out, but can anyone think of a reason that somebody might actually have had viral illnesses in the past, have received antibiotics, and then have felt that they did actually get better?
Mariam and Angeline have both said placebo effect.
Absolutely, yeah. So definitely that certainly could be one reason. So with the placebo effect, it sounds like you're all quite well versed in what that is, but it can be very powerful indeed. Just the act of taking something, a tablet, a medicine, receiving something that we believe is a treatment, even if there's nothing that's truly therapeutic in it, can make a real difference to the way that people feel. And there was an interesting experiment back in, I think it was in the 1970s, in which a researcher went to a group of medical students. I think there were about 56 medical students in this study, and they were about to go into a lecture. And he said to them that he was either going to give them some stimulant tablets or some sedative tablets. So stimulant tablets would make them feel more alert and energetic, and sedative tablets would make them feel much more sleepy. So he then gave them either 1 or 2 blue tablets to take before the lecture, or 1 or 2 red tablets to take. And what he found was that those people who took the red tablets were much more likely to report that they felt very energized and alert during the lecture, whereas the people who took the blue tablets thought that they felt more sleepy and less alert during the lecture. But as you'll probably have guessed or may already know, the tablets didn't actually contain any stimulant or sedative at all. They were just sugar pills. But just the fact that they took the tablets and they believed that the tablets would make them feel different did actually make them feel different. So it can be the same with antibiotics. If people think that it's going to make them feel better, it can actually make them feel better. Can anyone think of any other possible reason?
Our justice said that the antibiotics are unlikely to interfere with the body's natural defense mechanism against viral illness anyway, even if there wasn't a placebo. So maybe, I guess, your body's healing itself.
Yeah, exactly, actually. So it kind of relates to this thing that I just want to show you, which is the Sports Illustrated curse. I don't know if any of you have heard of it, but essentially this Sports Illustrated is an American sports magazine. So it's only the kind of top athletes who, when they're at the top of their careers, they get to feature on the front cover of this magazine. And there's this thing called the Sports Illustrated curse, which is that when people have featured on this magazine, people have often found that subsequently they don't seem to do quite so well in their career. And people felt that it oh gosh, if you appear on the front cover of this magazine, it's not going to be good for you, you're going to start doing badly. But of course, it's not really the fact that people are appearing on the front cover of the magazine that's making them do badly. It's really something that we call regression to the mean, which is that people appear on the front cover of the magazine when they're sort of at their pinnacle, they're doing their absolute best. So the likelihood is that their performance is going to go down a bit, or what we would describe sort of regress to the mean. And we can sort of use that analogy for people going to their GP with a viral illness, because people will normally present to their GP when they're feeling at their absolute worst with the illness. And so whether the GP does anything or not, the likelihood is, in most cases, that they will subsequently start to feel better, that is, regress to the mean. But if the GP has given the person antibiotics, then they may well falsely think that it's the fact that they took the antibiotics that's making them feel better, whereas actually they were always going to recover and feel better anyway. So essentially, when I was doing my GP training, I was kind of thinking a lot about all of these things, the overuse of antibiotics, antibiotic resistance, and how we could do things better. And so during my GP training, I did some research along these lines. How can we sort of diagnose and manage infections better? And I decided that I wanted to continue to do research going forwards. So luckily enough, I was able to get some funding for a DPhil, which is what they call a PhD in Oxford. So for the next 4 years, I was doing 75% research on the PhD, the DPhil, and then the other 25% of the time, I was splitting this between general practice and working as a community cardiology doctor. So what does this bunch of cranberries have to do with wanting to reduce antibiotic prescriptions? Well, I decided that I wanted to see whether we could better manage urinary tract infections, so infections, urine infections essentially. So unlike the infections I've spoken about before, like the acute cough, colds, urine infections are actually mostly caused by bacteria. So I've already mentioned to you that, and you're already aware, antibiotics treat bacterial infections. So if urinary tract infections are caused largely by bacteria, then shouldn't we be treating them with antibiotics? Anyone, just feel free to shout out your thoughts or put it in the chat function. So if you're a GP and someone comes to you with a urinary tract infection, you know, it's likely to be caused by bacteria. Should we therefore give them antibiotics to treat them? Any thoughts, guesses?
Yeah, we've had quite a few coming through. So Miriam says, yes, but maybe a cream rather than a pill, so it's doesn't go through the whole body, so something topical. Jessica says, not really. And Oja says, yeah, if we limit antibiotic use, then we can reduce the likelihood of resistance, so avoiding the use of antibiotics ideally. Yeah, that's it so far.
Okay, lovely. So to be honest, you're all sort of right, because the answer is, well, yes and no. So essentially, when somebody has an infection that's caused by bacteria, we can treat it with antibiotics, but we don't have to necessarily. It depends on the nature of the infection. And if we think back to, say, 200 years ago, people would have been getting urinary tract infections all the time, and we didn't have antibiotics then, and people would have recovered from them. However, we do also know that urinary tract infections can be very uncomfortable, and we know that giving antibiotics can help to manage them and make people feel better. So we have sort of national guidance from NICE, that's the National Institute for Health and Care Excellence. I think that's the right think that's the correct acronym. But so NICE provides national guidance about how we manage different conditions. And they state that if a woman comes to us and they have a urinary tract infection, assuming that it's not a complicated infection, so that is, there's no signs that they say have a kidney infection, they're not having high fevers or vomiting with it, then we could consider actually delaying antibiotics. So not giving the person antibiotics immediately and seeing whether they can try to manage the infection in other ways to try to avoid antibiotics. But even though we have this national guidance in place that states that we don't have to immediately give antibiotics for urinary tract infection, we know that in reality, in clinical practice, almost always, if a woman presents to a GP with a urinary tract infection, they'll almost always get an antibiotic prescription for immediate use. So I decided to think a bit about whether there are alternatives to antibiotics for women who have urinary tract infections, because they're so common and it's one of the commonest reasons that GPs prescribe antibiotics. Hence, I started thinking a bit about cranberry. So you probably, or you may well already be aware of cranberry. So a lot of people, if they have a urinary tract infection, they might be told or advised to drink plenty of cranberry juice. And it's always been seen as a bit of an old wives' tale. But I wanted to find out whether there was actually potentially any evidence behind it. So when I did a bit of digging into cranberry and studies that had been done, what I found was that, so just to explain this figure first, so E. coli is the bug that most commonly causes urinary tract infections. And they have these sticky out bits, these fimbriae, and they would typically stick to the lining of the bladder. The other name for that is the uroepithelium. So they'd stick to the lining of the bladder, and that then causes the urinary tract infection when they then invade the bladder lining. Now, cranberry contains a substance called PAC for short, represented by these triangles. Sorry about my clip art here. But PAC stands for proanthocyanidin. Okay, but I'll just call it PAC for short because it's a bit of a mouthful. Now, PAC is found in a number of different substances, a lot of different fruits and other foods. But the PAC that we find in cranberry is unique. And the PAC in cranberry has been shown in kind of test tube studies, or what we call in vitro, to block the binding of E. coli to the lining of the bladder. Therefore, it could, in theory, prevent a UTI from being caused and sustained. So this is what has been found by some researchers in kind of test tube studies, so outside of the body. But what I wanted to do was see, what about if we actually give people cranberry in a trial? Would it make a difference? Would it help to treat them? So during my DPhil, one of my main studies was running what we call a feasibility trial, which is essentially a trial but on a small scale. So you can see I recruited just 46 women to this study. So these were women who presented to their own GP practice, and they had symptoms of a urinary tract infection. Now, I've described it as an acute, uncomplicated urinary tract infection. When I say acute, what I mean is that their symptoms had lasted for under 7 days, so it's kind of a short-ish lived infection. And also it was uncomplicated. So these were women who didn't have any problems with their immune system. And these are also women who are not presenting with symptoms that suggested they had, say, a kidney infection, or that they were very unwell. So they didn't have sort of high fevers, they weren't vomiting, that sort of thing. So these 46 women were consented to take part in the study, and then they were randomly assigned to one of 3 groups. In the first group, they received immediate antibiotics. So this was described as the control group because this is what would normally happen if a woman with a urinary tract infection went to see their GP. In the second group, they got immediate antibiotics, but they also got cranberry capsules, and they were asked to take both the antibiotics and cranberry capsules at the same time. So the purpose of this group was to see whether giving cranberry in addition to antibiotics had an additive effect. And then in the third group, women were given the immediate cranberry capsules. They were also given antibiotics, but they were asked to try not to take the antibiotics. So the advice for people in this group was start off by taking the cranberry capsules alone. If after 3 days or so, you find that your symptoms aren't any better, or indeed if they get any worse, then start to take your antibiotics. So all 46 women were asked to complete an electronic symptom diary to rate their symptoms and also to record any treatments that they were taking. And when I got the final results and analysed them, what I found was that people who were in this group, so who took immediate antibiotics and immediate cranberry, seemed to have better symptom control than people who took immediate antibiotics on their own. And I also found that people who were in this group, the second group, and also in the third group, over the course of 2 weeks and also 4 weeks, they consumed fewer courses of antibiotics compared with people who were in the group 1, who were in the control group. So this suggested to me, and suggests to me still, that there may be some merit in pursuing this area. However, because I only tested this in 46 women, this is quite a small group of number, sort of a small number of women. And so I could have found these effects just through random chance. So what I need to do to see whether or not these effects that I have preliminarily seen are actually true is to test this in a much bigger group of women. So I probably need some hundreds of women to ascertain whether or not cranberry can actually be used as a treatment for urinary tract infections. So I'm currently trying to get funding for that. But my PhD ran from 2017 to 2021. And of course, during that period, something very important happened, which was the COVID pandemic. So when it got to March 2020, I actually just sort of put aside all of my PhD research entirely for about 3 months. And I just started to work on COVID-19 research. And one of the things that I got involved with was a clinical trial that was being led by my supervisor at the time. So you'll all be aware, of course, of COVID-19 vaccines, and the purpose of the COVID-19 vaccines are really to try and prevent illness, to prevent you getting COVID. And if you do get COVID, to hopefully lessen the symptoms that you get and reduce the chance of you spreading it on to other people. But unfortunately, we know that some people still do get COVID, and they can be very unwell when they get COVID. So we also wanted to think about, okay, if somebody gets COVID and they're unwell with it, what kind of treatments can we give them to help them to feel better? Now, normally, if we're developing new treatments for anything, it would take several years because treatments have to undergo several different trials, usually initially in small numbers of people and then in larger numbers of people. And this process is expensive and takes a long time. Now, because of the unprecedented nature of the pandemic, there were internationally efforts to try and develop new treatments. And even though the process was being done rapidly by researchers, developing new treatments still took several months. So in the interim, our team, so the principal team, which was led by Professor Chris Butler, my lead DPhil supervisor, we thought, can we take drugs that we already use and see whether they could actually be treatments for COVID-19? So the benefit of doing this is that we don't have to now start, trying to develop a new drug, so we can immediately start testing these drugs. We already know that they've got a good safety profile because we're already using them. The downside is, though, of course, they haven't been developed for COVID-19, so we don't yet know whether or not they will work. So one of the first drugs that we decided to test in this trial is azithromycin. So azithromycin is an antibiotic, and it's been used for many years to help treat chest infections and also bacterial skin infections. Now, I'm sure many of you are thinking, hang on a second, I've just been talking for the past 30 minutes about why we shouldn't be giving antibiotics to people who have viral infections. And of course, we know that COVID-19 is caused by a virus, the SARS-CoV-2 virus. So why on earth would we think about giving an antibiotic as a treatment for a viral infection? Well, in order to explain this, I'm just going to talk you through the life cycle of the virus that causes COVID. You probably have already looked into this, but just as a refresher. So again, apologies for my clip art here, but that red star-shaped object is the virus. So in order to infect a human cell, it attaches itself to a receptor on the surface of the cell. And then this leads to an uncoating and an injecting into the cell of the virus's genetic material, which is called viral RNA. Now, you'll be aware that the sole purpose of a virus is just to replicate itself, essentially, and to spread. But it can't do it on its own. So it has to hijack the cell's intracellular machinery in order to do so. So the viral genetic material, the viral RNA, attaches itself to a human ribosome, which leads to transcription and produces a number of viral proteins, one of which is RNA-dependent RNA polymerase. This polymerase attaches itself to the viral genetic material, and it makes multiple copies of the viral genetic material, the viral RNA, as well as also producing a number of viral proteins. So the viral genetic material is then packaged along with the viral proteins, again, making use of the structures in the human cell, like the Golgi apparatus, to make multiple new viral particles. And these then are packaged within a vesicle. This vesicle fuses with the cell membrane, and then this leads to the virus particles that have newly been created being expelled from the human cell and then ready to infect another cell. So, some studies suggested that azithromycin might actually help to block the pathway of the virus moving within the human cell by changing the pH levels within the cell. So it's believed that it would sort of inhibit the secretory pathway of the virus genetic material within the cell and also prevent the newly formed virus particles from actually being able to fuse with the cell membrane and be expelled from the human cell. Another thing is that normally, when a cell is infected with a virus, it leads to the production of small proteins called cytokines, which are important for the immune response. But sometimes, and we see this sometimes in people who are very unwell with COVID, there can be an overproduction of these cytokines, what we call a cytokine storm. And this can actually lead to damage to the human body. In particular, it could lead to damage to the lungs, which can cause something called acute respiratory distress syndrome. And azithromycin is believed to reduce the production of a number of these cytokines. And so we thought that from some of the evidence we had from, again, sort of test tube studies, in vitro studies, so studies conducted outside of the body, that azithromycin might be able to help treat people who had COVID. But again, we just thought about this in theory. We didn't know it for sure. So what we needed to do was to test this in people who actually had COVID. So we did that. We took people who had COVID in the community, and specifically we were looking at people who were at higher risk of becoming quite unwell with COVID. So for example, people who were over the age of 65, or people who had problems with their immune system that meant their immune system was weaker and therefore they were more susceptible to infections. And we gave some of these people azithromycin, and we compared them to people who received usual care, which in the UK was essentially just supportive care. What we found was that azithromycin in these people in the community did not reduce the chance that they would be admitted to hospital, and it also didn't reduce the chance of them being admitted to hospital with their symptoms. So essentially, we recommended that for people who had COVID in the community who were at higher risk of having an adverse outcome, so for example, older people, azithromycin was not a useful treatment for them. And as we've been talking about in this talk, particularly because of the antibiotic stewardship implications, so the risk of actually increasing antibiotic resistance, we said it was important that people should not use this antibiotic as a potential COVID treatment. So just to highlight there, but even though this was a negative result in inverted commas, actually it can be equally useful to get negative results as what we would describe as a positive result, that is finding, say, a drug that actually does help to treat. Because actually at the time, a lot of people were using azithromycin as a COVID treatment in different parts of the world. So being able to explain that actually it isn't helpful and we should stop using it was a useful message to disseminate. So I then got to the end of my PhD, and that really brings us to present day. So at the moment, I am doing postdoctoral research, so post-PhD research, and that's still in Oxford in the primary care department, which you can see here. My focus is still sort of infections and clinical trials work. I continue to work as a GP and also work as a community cardiology doctor. So that's the end of my presentation. Just to mention that I have published a few blogs about some of the things that I've discussed. You can probably see them if you look at my Twitter account. I've posted some of them there. But thank you very much for listening, and I welcome any questions that you may have.
Thank you so much, Kome, for that very interesting.
So actually, oh, sorry, just I'm actually now able to see the chat. So I can actually see some questions in the chat. So I think, Mariam, you wrote cranberry juice works. It was that when I said, why am I talking about cranberry? Yeah, exactly. So yeah, so with the cranberry, interestingly, a lot of studies have been done that have looked at the use of cranberry as a means of preventing urinary tract infection. And there have been quite mixed findings, to be honest. Also, unfortunately, a number of the studies that have been done have not been of the best quality. And a lot of the studies have used cranberry juice rather than cranberry capsules. So I use cranberry capsules in my study, but a lot of the studies use cranberry juice. The problem with this is that some of the studies that were testing cranberry juice to prevent urinary tract infections asked the participants to take cranberry juice, quite large amounts, daily for sort of a few months. And I don't know if any of you have tried cranberry juice, but it's not really to everyone's liking. And so in some of these studies, there was really high dropout rates, sometimes of, around 50% even of participants, because they just didn't want to keep drinking cranberry juice in such high volumes. And also, I talked to you about what we believe to be the active ingredient in cranberry, which is something called PAC, paranthocyanidin. So a number of the studies that have been conducted didn't actually specify how much of what we think is the active ingredient was in there, was in the product or the juice or the capsule that they gave to participants. So it was difficult to be sure of, exactly what participants received. So a lot of studies have been done looking at cranberry. The quality is mixed, and also the results have been mixed. But actually very few studies have looked at using cranberry as a way to actually treat an acute UTI. So if somebody has the UTI now, can it treat them, which is what I was looking at. I can see that I think Alia wrote, why are women more likely to receive an antibiotic prescription for a urinary tract infection? Just to check, when you say more likely, as in more likely than, Alia, do you mind just clarifying your question?
Sorry,
Do you want
to clarify?
So you said, why are women more likely to receive an antibiotic prescription for a urinary tract infection? More likely than what?
Than men.
Oh, I see. So actually, they're not more likely than men to receive antibiotics. It's just that urinary tract infections happen much more commonly in women than men. And if you think of the anatomy, women have a very sort of short urethra, whereas men have a much longer urethra. So bugs are can get into the urinary tract system much more easily in women compared with men. Actually, because it's much less likely that a man will get a urinary tract infection, if they get one, then they really should actually get antibiotics. We wouldn't be thinking about non-antibiotic treatments for them. So, you know, I talked about sort of complicated and uncomplicated urinary tract infections. In men, we would almost always just class them as a complicated infection that should therefore get antibiotics because they're much less common. Whereas in women, actually the majority of urinary tract infections are what we would class as uncomplicated. So there is potential for them to avoid antibiotics. And then Alia asked, why didn't you investigate the effect of cranberry alone? That's a really interesting question. I'll just go back to that slide. I hope you can, oh gosh. Yeah, hopefully you can see it. So yeah, so in the group that got the immediate cranberry, they also got the backup antibiotics. And really that was because we know that women who have urinary tract infections, although they may not come to any harm through it, they are in a lot of pain. And we know that antibiotics do typically help people's symptoms. So we didn't want to be cruel because although we hoped that cranberry would work, we didn't know for sure. So I didn't want to give people cranberry and for them to not have recourse to anything else that would be able to help them. So I felt really from the perspective of the patient's symptoms and also from an ethical perspective, it would be important that they would have access to backup antibiotics, that is the delayed antibiotics. But there were a few women who just took the cranberry and they didn't need to take the antibiotics. But actually a number of women in this group started off antibiotics. And then you said, please could you explain again why antibiotics are given to COVID patients? So essentially, antibiotics might have some sort of beneficial effect in COVID, which was not in the way that we would normally, or not the beneficial effect that we would normally expect. So normally, of course, antibiotics. However, some research suggested that actually certain antibiotics, like azithromycin, might have a sort of anti-inflammatory effect. And this could potentially help people who had COVID. And again, certain research suggested that the antibiotic might actually prevent or sort of inhibit the movement of the virus within human cells and therefore prevent its replication. So there was some evidence that perhaps it could help, but we then needed to test this, sort of going from test tube studies to actual real studies in human beings. When we tested it in human beings, we didn't find that there was any benefit. And we thought that actually there's probably increased harm through doing it because of the risks of antibiotic resistance as well. I hope that makes sense. Let me know if it doesn't. And then Oja says, besides GP training, what other specialties would you say can be balanced well with research? Really interesting question. So I feel that general practice, like you say, I think it does lend itself well to being done alongside research. But research in general practice is actually one of the it's one of the newer specialties to actually sort of really develop a research ethos. So research is or can be a part of pretty much any specialty if you would like to do it. So I wouldn't say that it's really, I would say that all specialties really can be combined with research. Yeah, I don't think there's any that I would say you can't do research with. And there are specific posts. So during my GP training, I applied for an academic clinical fellowship, which gave me some dedicated time to do research alongside the GP training. And I think that in pretty much all specialties, you can do an academic clinical fellowship that would give you a bit of research time alongside your clinical work. And then Alia has written, how does the PAC, so PAC in cranberry block E. coli from binding to the bladder? Is it blocking a protein binder? Yeah, so it's believed that it blocks specifically the P. pili. So these P. fimbriae that are on the end of the E. coli bug, it's believed to sort of block the P. pili from, so it sort of blocks or attaches to the P. pili, which stops the bug from therefore being able to bind to the lining of the bladder. And then Alia asks, could painkillers not be given to relieve women of any symptoms of pain alongside the cranberries? Excellent point. And yes, and in fact, there have been some trials that have been conducted that have compared anti-inflammatories like ibuprofen as a non-antibiotic treatment for people who have a urinary tract infection. And what they have found is that when they gave people things like ibuprofen, so it's, for example, they randomly assigned people to get ibuprofen versus an antibiotic. So they found that if people were given an ibuprofen, they were much less likely to, so in that group, far fewer people used antibiotics compared with, of course, the group in which everybody got antibiotics. But they also found that people's symptom control was less good if they just got ibuprofen compared with antibiotics. And they also typically found that people had, there were more cases of kidney infection, what we call pyelonephritis, in people who just received ibuprofen compared with people who received antibiotics. But in the current guidance that we have for urinary tract infection, people can take pain relief and also, increase fluids as an initial treatment. And, if they didn't get better, then they can try antibiotics as a backup. So you're right, that is definitely one potential management strategy that can be used. From some of the interview studies that I've done with women with UTIs, they often stated, though, that they just didn't really associate painkillers with being a urinary tract infection treatment. I won't go into too much detail about this here, but you can also look at some of the blogs that I've written, I think, that touch on this a little bit. And so they were keen in many instances to find other or to have more sort of non-antibiotic treatments that could be used for urinary tract infection, hence thinking about cranberry as one potential alternative as well. But painkillers is certainly one option. Any other questions at all? Or any questions that I've missed, sorry.
I can't seem to see any other questions, but thank you so much for answering all of those questions. Have you received any personal questions through Zoom?
I think, I think there's one message just saying, what advice would you give to aspiring medical students, current medical students and foundation? So what do you give to aspiring medical students? Oh, current medical students and foundation doctors. Oof. I think I would say very broadly that I think medicine is an amazing career. I talked about the variety within general practice. but there is so much variety within medicine. And I think that's one of the great things, that hopefully there is a specialty that will suit you. Don't worry if you feel you haven't made the right choice initially. I didn't. I went for obstetrics and gynecology. You can always change path. And I think it's much better. Well, in my case, it was probably the best decision I made in my career, making that change rather than thinking, oh, just stick with it. I'd also say, if you are interested in research, which I personally really love doing research alongside clinical work, it's good to try and get involved in research early on. So that's why, you know, Oxford and Cambridge, I think, are great. Also places like Imperial, where you are you have to intercalate. So that means you do that extra year where you kind of do a research project. It's good to get a feel for whether you'll like research early on. So if you do it during your medical student years, that's great. And even if you don't, if you don't intercalate, then you can still get involved in research projects if you just speak to, you know, different your professors, or speak to other people. You can always try to get involved with research in that way. And certainly in your foundation years as well, although I didn't, you can do academic foundation programs. So try to get involved with research early on. I think, yeah, that's probably the main thing I would say. I mean, and also, I'm sure, of course, you all know, it is really hard work, but I think it's very worthwhile, very rewarding career. And then someone's asked you, why did I change from gynecology? Yeah, so I think when I was a medical student, I really enjoyed obstetrics and gynecology. And I wonder if it's partly because when I did my obstetrics and gynecology placement, the consultant that I was attached to really sort of took me under her wing, and, you know, she would take me to all of her clinics and just really made me feel like I was a very valued part of the team. I think that can have a huge impact on you when someone kind of, yeah, just really takes a real interest in you. So I think that made it stand out for me a bit more than perhaps some of the other specialties. But when I then started the reality, or the actual, you know, working as an obstetrician and gynecologist, I realized that a lot of the things that I think, if you want to do obstetrics and gynecology, there's lots of kind of emergency work. So if you're covering the labour ward, then there are lots of, you're often running from emergency to emergency. Say, emergency cesarean section, you've got to really rush, go to scrub up, immediately get to the surgery. There might be major obstetric hemorrhages, you've got to rush, you know, to do those things, lots of emergencies. And I realized that a lot of people who enjoy obstetrics and gynecology probably get a bit of a buzz from all of that, whereas I didn't. And what I found was that I was much more interested in the medical side of things. So in Oxford, there's an area, I've actually forgotten what it's called now, but there's an area where we would be able to see patients who had kind of medical problems alongside being pregnant. And I realized that I was much more drawn to seeing those people and sort of dealing with more of the medical side rather than the surgical side of the emergencies. So that was one thing. And I think number two, just when I did general practice as a foundation doctor, I just somehow found that I really enjoyed it so much. And it was just not, the experience I had working as a GP was very different to my experience of observing general practice when I was a student. And I found I just really enjoyed it, having sort of developing a rapport with patients and sort of interactions that I was having. So yeah, so that's why I just decided to make the change. And then, can you intercalate in other courses that are not science related? Yes, you can. Well, okay, in my day, a long time ago at Cambridge, you certainly could. I presume it's probably the same now, probably the same at Oxford. I know a couple of my friends did theology and other things. Most people did do science related, you know, did intercalate in science related courses, but you could do other things. But we'll be able to give a more current take on that for Oxford students.
Yeah, so at Oxford, it's generally medicine science related, but I've got friends at Imperial that I think they did like management, or they looked at health economics and things, which are really important and interesting things. So yeah, I think it depends on the university that you go to, what you can intercalate in.
Okay, that's very helpful to know. So yeah, apologies if what I've said is out of date, not relevant to Oxford, but yeah, in my day in Cambridge you could. But it's worthwhile finding out in advance, actually. And someone's asked, does Cambridge care about your GCSE grades when you apply for medicine? Again, do you know what? I am speaking, so I studied at Cambridge back from 2004 to 2010, so it was a bit of a while ago, I'm afraid. But I think they do take it into account, yes. However, I wouldn't say that you should, perhaps if you didn't get the grades that you hoped, I don't think it should necessarily put you off applying. It's obviously a very personal decision to make, but there are lots of different, my understanding is there are lots of different things that are taken into account. It's not just GCSE grades. You know, they're also going to look at your personal statement. Actually, sorry, in my day, we did AS levels, but you don't do that anymore, I don't think. Is that the case? But also can you look at your predicted A-level grades? So there are different things that people will be looking at. And certainly if, you know, I wouldn't want you to think that you should be put off applying really on the basis of perhaps GCSE grades not being necessarily what you hoped. Yeah.
I guess, yeah, if there's no further questions, yeah, thank you once again for your talk. It's been amazing with you, talking about the things that you've done and also, the research that you're doing right now. I was just wondering if I could ask all the participants just to fill in a feedback form. This will be really useful just for both Kome and also Steph, just to let us know, are you guys interested in these things and what we can do in the future to, get you guys involved and what you like to hear about. I'm going to post that in chat now. Yeah, so please, if you have time, just please fill that out. Yeah, I guess. Yeah,
oh, sorry, this is another question that came through.
Yeah, I can't see your
Someone asked, what's Cambridge Medical School like? So, as mentioned, I had a really nice time. It's very similar to Oxford. So, or it was in my day, I'm pretty sure it still is. But so you have the 3 preclinical years, which are principally science-based. So in our first year, we did, the focus was anatomy, biochemistry, physiology. In our second year, then we did sort of neuroscience, pharmacology, forget some of the other things, but all science. Then in the third year, that's when we intercalated. So I chose a pathology, I chose to intercalate in pathology. And then years 4 to 6 are then clinical. So that's when we then actually go into hospital, start seeing patients. For me personally, I really liked the way that it worked in terms of initially learning all of the science behind things before then actually applying it in the clinical setting. And one other thing just to be aware of that I didn't actually know until I was in my second year. And again, actually, it's good to check this because just in case things have changed from my day. But when I was at Cambridge, they had about maybe 300 and something students in the preclinical years, but they only had space for about half of us in the clinical years. So you then had to do another interview to actually remain at Cambridge. Well, some people wanted to go, so some people were interviewed to move to Oxford, other people were interviewed to move to London schools, but a number of people did want to stay at Cambridge. Not everyone was able to. So it's just worthwhile bearing in mind, first of all, research, check it is still the case. I don't know if they've increased their capacity for the clinical years, but in my day, you did have to reapply to stay at Cambridge in the clinical years. And there were maybe about capacity for about 150 of us. So it went down by about half. But no, I really enjoyed it. Great medical school. Yeah, I really enjoyed it, I have to say. Very hard work. I mean, medical school anywhere is hard work, of course. It is really hard work. It's very intense. Same as Oxford, really intense, 8-week terms, and it's hard. For me personally, though, I'm really glad that I did attend there. And I think it really stands in good stead for the future. But the truth is, wherever you go to study medicine, I'm sure you'll have a great experience. But, I really do think Cambridge was great personally. And I think Oxford is also great. Someone asked, what are the lecturers like? So just the lecturers or the lectures? Do you mind just clarifying quickly? Both, okay. So the lectures, quite full on. I think it's probably common at most medical schools across the country that, unlike maybe other courses, Monday to Friday, you're pretty much in lectures 9 to 5. The lecturers, variable. I mean, some were really engaging, others not so. I mean, I have to say, by the time you're getting to 40 minutes into lecture, often I was starting to feel a little bit sleepy. I think I wasn't alone, but you kind of get used to it as you're just in lectures for kind of quite long periods. I think it was a very well taught course. And, as you'll be aware, I'm sure, in addition to the lectures, we also had supervisions, what they call tutorials in Oxford, to help supplement the information that you get from lectures. And I think that's probably something you wouldn't necessarily get at other universities. Any other questions at all? Yeah, just to say, it's a real pleasure to speak to you all, and it's so exciting that you all want to apply to Oxford or Cambridge for medicine. But no, really exciting, and I definitely wish you all the best. All the best.
Thank you everyone for coming today, and I hope you've learned a lot. It's been amazing. One thing I was wondering, if I could, if you sent us your blogs, we could perhaps pass them on to some of the students, and they might find that really interesting.
Okay, no, sure. I'll do that. I'll send them. Well, if I email them to you, and then you can forward them on.
But yeah, thank you everyone once again, and if you can fill out the feedback form, that'd be amazing. We're getting a lot of thank yous through the chat. So.
Oh, my pleasure, as I say, my pleasure. Thank you so much for turning up. During the evening, I'm sure you've got other things you'd like to be doing. So, yeah.
I think I'll end the meeting there. But have a good night, everyone. And if you've got any questions about applying to medicine or whatever, just please email us at stepinto.oxmed, and we'll do our best to answer your questions.
Okay. Take care. Bye, everyone.
Bye.